to another Department of Family Medicine Research Seminar. We have a great turnout today and we have a fantastic presentation lined up. Before we begin, I'll just introduce myself. My name is Aliza Ganai and I'm the moderator for today's panel, and I'm an MSc student in family medicine working under the supervision of Dr. Kate Rice, studying patient-centered obstetric care. I'm also a researcher at the Biomedical Ethics Unit, working with Dr. Phoebe Friesen on community-led research ethics governance. And I'm joining the Zoom today from Tiohtià:ke, Montreal. And I would like to acknowledge that myself and McGill University is located on land that has long served as a site of meeting and exchange among Indigenous peoples, including the Haudenosaunee and Anishinaabe nations, and that McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. And, perhaps it's appropriate to follow from our land acknowledgement a short reflection that Neil asked me to share with you. So Neil asked me really interesting and thought-provoking question. What does cultural safety mean to you as a student researcher who's interested in anti-racism? And I've actually had the opportunity to learn from Neil and Dr. Alex McComber in our department in my coursework about cultural safety. And to me, cultural safety in the context of my research on obstetric care is an outcome of working to alleviate power differentials. So whether that be at the interpersonal, institutional, or structural levels. And I think that this requires a level of critical consciousness to be able to recognize and intervene on oppressive forces such as racism and colonialism that we'll be talking about today. And as an MSc student, it means having self-reflexivity and being critical of the way that I think and design and conduct research, and ultimately the knowledge that I produce. So, I encourage you to reflect on that question as well. And, with that, I will introduce our amazing speaker today, who's Dr. Neil Andersson, and he will give us his presentation on safe birth and cultural safety. Global experience can build local solutions in Quebec family medicine. And I'm sure many of you in attendance know Dr. Neil Andersson and his amazing work, but for those who don't, Dr. Andersson is a physician and epidemiologist who has studied birth for 4 decades. He is the director of the CIET participatory research at McGill in the Department of Family Medicine, and he is a co-director of the McGill Institute for Human Development and Wellbeing. So before we start, I just want to remind everyone that the presentation will be about 45 minutes, and we will take about 15 minutes at the end for discussion. And if you have any questions for Neil, please type them in the chat box or raise your virtual hand during the discussion session. And this seminar will be recorded, so I think it's recording already. So if you don't want to be in the recording, please have your video off. And just a heads up, Yvonne will be putting links for the materials that Dr. Neil Andersson will be referring to in his presentation. So with that, off to you, Neil.
Good, thank you very much. Let's see if we can share this. Is it sharing yet? Seems to be.
Yeah, it's working.
Can you see my wonderful graphics? Good. Well, thank you everyone for coming. And it's quite humbling to see so many known names and familiar names. Unfortunately, your faces are these tiny little things on my screen, but I'm very glad to see you all. So as we start talking about safe birth and cultural safety, I'm pretty sure that whatever the angle we come at it from, we've got pretty much a shared view that what we're talking about is broadly a good thing. And who's not going to be in favor of safe birth and who's not going to be in favor of cultural safety, even if we have different understandings of it. So I wanted to start by sharing with you a story of my personal motivation in this area, or a big part of my personal motivation coming from my very early training in neonatology. I was attending as a neonatologist in an operating theatre for a cesarean section of a woman who was in her 3rd or 4th pregnancy, and the child got into some problems, and so we were on standby. As it turned out, that was all okay. But at one point, pretty soon after everything settled down and we were just standing around, the nurse who was assisting suddenly, very abruptly and conspicuously turned away and went and stood in the back of the theatre. And so everybody kind of, whoa, what was that? And the surgeon carried on. And I found out afterwards that this surgeon was known for crushing the fallopian tubes on multiparous women. And this nurse was having none of it and turned away. But I didn't understand it then, what could lead someone to do that? And I still don't really understand it. But it is sort of the topic of the discussion, and certainly the motivation and the understanding of what is not safe birth. And I used the example to introduce the idea that safe birth is not just the absence of Western medical care. And sometimes unsafe birth is the way that Western medical care is shared. So I'm pretty sure that everyone's got their own horror stories, and I'm not trying to out horror, but I did want to raise that issue so that we can start talking about why that would be the case. There is a certain pressure and a certain way of being that has some people weighing up as an either or culture and safe birth. The reflex being that I'm a physician or an obstetrician or somebody involved in Western medicine, and what I know is the technology of safe birth, and I can do that well because it's what I'm trained to do. I'm not trained to know about everybody's culture. So culture for me is risk, mostly because it's unknown. So there's a tricky proposal there, which says that because I don't understand it, it's risk. There's no stopping to say, well, hang on, it could actually be a major enrichment. And it's my opening proposition that we can show that culture not only is not on a balance with cultural safety, but it stands to push behind, culture is not on a balance with safe birth, but it can stand behind safe birth, making it safer and getting other benefits. So for those of you who have got other things to do, that's kind of the message, although it'll be a bit more detailed than that as we go through it. I suppose that's the central message, that this is not a balance, it's not an either or, and I think the sooner we start to do that, the better. Now, there are different and more modern views of interculturality that have been eroding this rather archaic view of cultural risk, just interpreting all cultural difference as risk. The first of these is well known to you, which is cultural sensitivity or cultural awareness. And again, not a bad thing, but it's very much a view from the one side of the fence. Cultural competence is something that we hear a lot about, and there is a big literature on it showing how cultural competence, where this is present, has better maternal outcomes, safer birth than where it's not there. And that kind of makes sense. There are a lot of discussions about cultural competence, not least the fact that this is something, a designation, an appellation that is given by those in the dominant group to themselves. It isn't actually something that those they're referring to have any say in. And so that's a bit of a puzzle to start off with. Cultural humility starts to change that in the views of interculturality and say, well, look, ask yourself some questions. Are you sure that this is a risk? It might be a major benefit that people belong to this group or this cultural group or that cultural group, or that they have this number of centuries of traditional knowledge that you don't have. That humility is a step above the self-declared level of competence. There are modern writers that have presented cultural competence and the claims of cultural competence as a new form of racism, because it's basically has people pushed on the other side, and I'm the one who's going to decide what the appropriate way to deal with you is. Cultural safety turns all of that on its head. And the fact that a group, and this started with Indigenous groups, the group is seen as other, means that you have to ask the others how they see it, and it hinges on that. There are further and more elaborate formats to this that we'll be discussing a little bit as well. So a few words on cultural safety. This has its origins in the modern literature. It has been discussed for decades, but it's got its presence in the modern literature in the 80s, really starting from the Māori healthcare context in New Zealand, where they basically said, you know, you talk about ethical safety and you talk about physical safety, but what about cultural safety? And what about it? The key thing here is who gets to call it safe. And I can be whatever kind of good family doctor or whatever kind of good obstetrician I like. It is still not my call to say what people are going to find culturally safe. That's so the primary division here is that they get to say whether it's safe. Now, in acknowledging that, the first thing that happens is that we're expressing and externalizing respect. And in that relationship, that newly formed relationship might say, well, you've got a whole lot of stuff that I don't know. What can we say about it? Just that step of saying it's your call, whether this is safe or not, sets up a relationship of mutual respect. It also sets up a self-reflection. A self-reflection of, well, who, you know, particularly when I start hearing the answers, who was I to think that I knew more than that person, just because, you know, I spent whatever it is now, 14 years learning about medicine. I want to share with you a series of stories. They're not from, I'm not declaring these as my project. Of course, I was involved in all of them, mostly from a very early stage in them. But this particular project comes from the work of Anne Cockcroft. And the concern here was maternal mortality. So very much, you know, outcomes of safe birth and who doesn't make it. And the concern here was that a lot of resources get pumped into maternal health care, and a lot of countries say we're very proud of our coverage, and they say coverage of 80%. For those who are concerned with safe birth, 80% is not even at the table, because the health events, the disastrous, the catastrophic events to do with safe birth happen in the other 20% that you didn't get to. So the only way is to have both a philosophy and a practice and an investment level that is true universal coverage, that everybody is in the picture. So this particular project was looking at that and going at it with the idea of customizing the care for the local populations, because one of the big things that happened is that the concern about maternal mortality had this huge international push behind it, where people from the US, Europe, Canada, put the dollars in and imagined that that gave them the right or the obligation to say what should be done with them. I'm not knocking investment. You've got to invest in maternal risk, but you don't have to push your ideas down other people's throats. So the way we started was to develop a complex evidential base of maternal risk and large surveys where we found very specific risk factors. The 4 factors that explained something like 80 to 90% of negative outcomes were gender violence in the last year, gender violence during pregnancy, heavy work in the household, and not discussing with the spouse, not discussing pregnancy issues with the spouse. Now you can see from that, that anybody who comes down the pipeline saying, okay, to be safe, for maternal safety, what you need is 4 or 5, whatever it is for the particular part of the country that we're talking about, 4 antenatal visits. And that'll make 4 antenatal visits don't deal with any of those 4 things that explain 80% of negative outcomes. So what we're really wanting to do is to say, okay, what is explaining the negative outcomes? What makes for unsafe birth? And deal with that. So this implication of men, all those 4 things, gender violence in pregnancy, not talking to the spouse, and too much work, it's got men written all over it. And the question is that whatever else you do, if you're going to leave those 4 things intact, you're not going to change maternal mortality in this community, whatever the coverage you get of your antenatal care or anything else. So what we did was basically start home visits, universal home visits, where we took this information of those 4 risk factors to communities, to every single pregnant woman, and with a separate visitor, a male visitor, to her spouse, to discuss this and say, these are the 4 things that we've got. What do you think we can do about it? Now, a bit of a spoiler here. We never said, you shouldn't beat your wife. We never said, you mustn't let her work in pregnancy. What we said was, people with these factors have these outcomes. Who can do what about it? And people discussed, and frankly, it was that level of participation, of engagement, of household level prevention design changed the picture completely. Now, this is work led by Anne Cockcroft and supported by a few other people that I see here. I won't name them all. But it actually had an amazing effect. In addition to men's attitudes changing by being in this dialogue, gender violence changing, we also saw changes in child health behaviors because they were much more sensitized, things that we hadn't discussed, but because they were much more involved in it, those things changed. Of course, the maternal risks went plummeting, gender violence went plummeting, as people just discussed these things, not from being preached at, but from being engaged in the design of what would safe birth take to make here. And the kind of things they said are reflected here. I'll give you a minute or two just to skim over them. So combining this kind of narrative evidence of how people genuinely changed from being in this, we called it a dialogic intervention because we were discussing results and taking their own decisions. Not only did the things change, but they probably stayed changed. There's one more example from Nigeria that I'd like to share with you that shows a very different thing. So this one tells how a culturally safe research method, a single simple method, cracked a very hard old nut in reproductive health. And that's culturally safe child spacing, what somebody would call family planning, birth control. It always impressed us in this project that there were a huge amount of resources pushed into family planning. And because we were working in the communities, they got these resources, and it was necessary to do something about it. And they gave us these books, lots of books about what you must do to push family planning. It wasn't quite the approach that we were able to or prepared to use. But what we did do is decide to discuss these issues with communities. And we found that communities had their own structure of understanding it. They had their own words for it, kunika in Hausa for short birth interval. It was very established as a health-related problem and complex, detailed, lots of approaches to it. So what we did was open discussions with the communities. Again, this is work led by Anne Cockcroft, about what it would take to have no kunika. In other words, the interval that is not too short. Without saying, you know, we define safety as this, you've got a definition, you understand what this thing is. What will it take to avoid that? And they sat in groups, older men together, younger men together, older women together, younger men together, religious leaders apart, each of them making a map of what it would take to have no kunika. And then we put those maps together. And here you see it with some of the participants. Oops. So what they do practically is they write, a moderator writes the words on one of these stickies. We later used magnetic, because it was so successful and everyone liked doing it. We started using magnetic stick-ons on a board. You can also do it directly on a computer. You can also draw it on the ground. There's just no limit to the way that you can do these maps. You put the concept together, you then discuss them, and is this like this, and is this part of that? So you get them into these little clumps. You then put arrows to say what leads to what, and then you weight the arrows. You start by saying, which is the strongest of all of these linkages in the whole thing, and they choose the strongest, and they give it a 5, and then you say, which is the weakest of all of these, and you choose it, and you give that a 1, and then you go through all of them one by one, and you weight it. So practically, what this lands up being is an action map, a feasible action map that people can pick up and turn into strategies at home, strategies in the services, strategy at policy, and if they would listen to it, strategies for international investors in maternal health. When I see a map like this, I have one of these deja vu moments from when I was at medical school, which was a long time ago, when in the days when we still would have been very impressed if somebody said, one day there's going to be something that they call the internet, but it's true. Anyway, so and there was this molecular biologist was telling us about the developments in his field, and it was interesting enough, you know, all DNA and RNA and all this wonderful stuff. But everybody was very kind of theoretical, a bit like, you know, internet was in those days. And then he had this bucket and put a stick into the bucket and pulled out this lump of sort of spaghetti-like stuff. And he said, and that's DNA. And everyone went, whoa! Now, that's kind of what I'm like in relation to this. I find it so cool that a group of community members can sit down for a couple of hours and explain why $1 billion, $10 billion, whatever it is now, I don't even know what the total investment in family planning in Africa is. But in a couple of hours, they can explain why, not only why it didn't work, but what it would take to have it work. And the key here is a culturally safe research approach, addressing a problem that is everybody's problem. We share this idea. Nobody wants unsafe birth. So another case from Uganda, where we followed very much the same approach. Here, the specific issue was access to perinatal care. The health services could absorb more people. They were aware that some people at the back of the queue weren't getting in, and they were very interested to change that. So we did rather the same thing. We used fuzzy cognitive mapping, as we did in Nigeria, to define the problem. We developed the tools for it. We looked at the survey. We worked with them on designing the fixes, and we would go on to measure the impact. What we found in that setting was a little bit depressing, because although we were talking about it, the main thing women were talking about was their fear to go to the health services, that their husbands might not support it, they might not be dressed right, they might not have the hygiene, as it was called, that they required, or it might not be because they were too poor to have the equipment, because the way that universal coverage worked in North Uganda at that time was that everybody had access. There was free access. You just had to bring your own things. And if you don't have the money to get them, well, you can't go. So you see, here we land up with a very complex knot of problems. There are problems at home, problems with the healthcare workers, obviously some cultural divide there, and problems of poverty, just sheer not being able to afford even a free service. So going back to that, I'll share with you in a little while. Well, I can share it right now. That the main take home here is that the fact that you're concerned with safe birth in cultural safety, the fact that you use culturally safe approaches doesn't change the deep problems. The deep problems emerged over decades. Us going and working with the groups for a few hours here and a few hours there doesn't change anything, but it does start the change. And I guess that's the big lesson with the next one. In Guerrero, Mexico, I see we've got a lot of Mexican colleagues present. This is work that is led by Sergio Paredes and is the basis of really a long partnership. I remember the initial meetings when we were discussing this in the late 1980s, starting to work with these communities. So it's a part of a very long-term partnership. And what these communities asked the research team at SEAT to do is to help with maternal mortality. They just said, we're losing women, too many. We wanted to stop. Can you help? So as we looked at it, we saw that the one thing that they did still have was a very lively culture of traditional midwives. And so the whole intervention was to try and support traditional midwives on their own terms. And here I want to make very clear right at the beginning that when we talk about traditional midwives, we're talking not about a qualification or a government appellation or a certificate. We're talking about the recognition within their culture that this person is a significant knowledge bearer, and that we use the number 10 in a year. A lot of people had asked for their help in relation to deliveries. So these are not the neighbor who happened to be going past when the woman went into labor. These are people whose career and job and life is around midwifery. The second thing to make clear is that in this context, in indigenous communities in southern Mexico, a midwife is not just a birth attendant. They do deliveries, but they attend through the whole pregnancy. They attend from menarche through to menopause. They also advise about family relations. In other words, it's somebody with huge skill, huge knowledge that cannot, with any straight face or justification, be confused with an untrained birth attendant or a birth attendant trained by Western authorities to do their sort of delivery. These are people who have got their own technologies, their own standards of safety. So our question was not to know or to change any of that. It was just to say, what do you need to do your work better and to interface with the services in the way that you want to interact with them? And it was very clear. They sat around for not very long. Within a couple of weeks, we had a very clear idea of what they wanted. And it was fairly simple. They wanted apprentices, because one apprentice per midwife, because they were getting old and they were worried about the knowledge dying out. Some of them, about 1 in 5, 1 in 6, wanted a birth station because they lived too far away from the main part of the community. They wanted a birthing station in the community where they could attend people. And the other thing they wanted was an intercultural broker. They didn't call them that, we called them that. Somebody who could speak Spanish, because many of them didn't speak Spanish, who could interact on their behalf with the health center. And when they referred women to the health center, they could be sure that the health center would understand what the issue is with that woman that they were referring. They also said that if you can do anything about these attitudes, we would like that. These attitudes of disdain and prejudice and stigma that we're receiving from the health services. Now, at that time, it was a very hard divide. The health services were staffed by medical students becoming young doctors who had never even heard of the term cultural safety, who were trained to believe that they were superior from indigenous people, who were trained to believe that everything to do with that was mischief or witchcraft or something. In other words, there was very little space for dialogue. Midwives could not be easily in the same room as these doctors. So what we're talking about in this project is the very first stage of opening space in which we would grow a dialogue. And so the way we did that was, as we do with all of the others and always, is with evidence. So we did a pilot trial where we basically said, okay, the intervention is to support the midwives in their own terms. We did the pilot trial. One of the results of the pilot trial was very dramatic drop in gender violence. And that gave us heart to move it on to a bigger formal non-inferiority trial. And the trial that was structured to show that somebody attended by a traditional midwife is no worse off in terms of maternal outcomes than somebody who is not attended by a traditional midwife and finds their way within the usual finding one's way. The next step, and this is the difficult one, is that this needs to go back to the services, all of this information, as grist for the mill, as what we're going to discuss, how we're going to get into a dialogue about safe birth in cultural safety. So I'm emphasizing this because I'm not wanting you to think that this big, difficult, imaginative, strong project, as it was, changed everything for everyone. It changed things in the communities, but not everywhere else. So the results of the study, and the results, these were studies that were analyzed by Ivan Sarmiento, who you'll also see in the list. And he also did a whole lot of very imaginative and strong work on systematizing the knowledges of traditional midwives and contrasting those with literature, knowledge from the literature and knowledge from researchers. So he's done a huge and complex piece of work, but one of his results was that there were very significantly fewer health problems in the intervention group. So we're talking here of 40 communities who received this support for, as it turned out, 30 traditional midwives, and 40 communities that did not, about 850, something in that region, pregnancies that went to completion during the time of the study. So 850 is not a big number when what you're measuring is maternal death and perinatal death. But there were significantly fewer perinatal deaths, neonatal problems, and childbirth complications, which is exactly what we wanted to show. So the reason why there were fewer is that one of the important things that this project did, supporting traditional midwives in their own terms, one of the important things it did was to open channels to refer people. So suddenly, women who were had complicated issues of pregnancy were getting referred, whereas they weren't in the control communities. So we were only trying to show that it was not worse. In fact, we landed up showing that it was considerably better where there was the support. We also showed that there was more traditional childbirth. The work was also more culturally safe. In other words, this was the first formal proof of safe birth in cultural safety being a better thing than the medicalized birth that is our alternative to this route. Now, one of the caveats here is that we were only able to show that improvement in the deliveries that happened at home. We weren't able to show a massive increase. There were a couple of things. They were allowed to choose their position more, their birth position more than in the control communities. But there wasn't much going on by way of cultural safety in the institutions. Despite that, an improvement in outcomes and some improvement in cultural safety. So the next phase of this work is to start working with the institutions here using very strong randomized controlled trial evidence to say, look, we're not talking anymore about those horror stories, either the horror stories of how people were mistreated by westernized birthing practices, or how things went wrong for somebody who didn't come to the westernized services. What we're talking about here is these are people who had supported, in the sense of not frowned upon, not put down, traditional midwifery. And this is how they did. So that project has now received funding. It's also led by Sergio Paredes. We'll all be waiting for our roles in it from him and taking it forward. So in each of these projects, I asked about the take-home messages from the lead researcher. And in this project, one of the messages was that, the big important thing is that this is the first study ever to prove that safe birth in cultural safety is a thing. It works. The observation of this particular researcher was that there is also an economic dimension that argues in our favor. This is not just an investment. It's a way of getting returns, getting benefits that are not just health benefits. There are social benefits too. I mentioned in the pilot study where we measured gender violence. Unfortunately, that didn't work out in the main study. It wasn't done properly. But these sorts of ripple effects of cultural continuity land up being tremendously important. So his suggestion was that it makes sense to make use of all of the resources. So you can see that this is a very different frame to the cultural risk frame that just says, because you're Indigenous, I'm considering you a risk. This is saying, you're Indigenous, you've got resources, you've got knowledge. What can you do? What can we do to help? It's a very different framework. So our next project comes from Nunavik in northern Canada in the Arctic. And the concern here was birthing outside the community. Now, I'm not going to try and pronounce this wonderful word in Inuktitut, but it means birthing outside the community, which is seen as a very high-risk thing. It is actually based on legislation. In Canada, there is and has been for the last 50 years, evacuation for childbirth. In principle, it was evacuation for those in the name of safe birth. Since then, it's gone on. In this particular region, with about 10,000, a bit more than 10,000 Inuit, about 300 a year get evacuated to Montreal The situation is much better now than it was, but it is by no means culturally safe. So what this project does is try to address what people are losing. People lose agency, people lose their culture, people lose their linkages with their families as they move down, often for months, to thousands of kilometers to the south to live in a city when they're used to living in a beautifully clean northern settlement, and they have to come and live in Montreal. So our idea was to start, as we do always, with getting evidence of how people see it. How do the people from Nunavik define cultural safety and culturally safe birth? The framing of that was started with fuzzy cognitive mapping again, very useful tool for starting, because it's an easy start. There are no language requirements, no educational requirements. You only have to be concerned about the issue. Followed by member checking, making sure we've understood it properly, and then adding that together as we get the fuzzy cognitive maps from the young women, from their partners, from the service providers, putting all of the pictures together and trying to work out what the route is. That would go forward into a dialogue, some kind of priorities about what needs to be done next. And then in a second phase, we would be implementing the fast turnarounds and discussing the system changes that had to happen. Now, I'm very happy to say that this is already starting to work. Just the fact that that we're starting to ask these questions, that the answers are coming through, and that those answers are so informative, has already started a run on the results of this project. So the PhD student who's doing this work is not on this call because right now, as we speak, she's briefing the Nunavik Perinatal Risk Committee. That might not be its proper title, but that's what their portfolio is on the preliminary results from the study. So it's already garnered an interest. The great thing about this particular project is that everybody wants to change. This is not like the Mexican one where there's, where the belief is what we've got to do is stop traditional birth. In this project, service workers, managers in the Montreal hospitals are saying, what do we need to do? They're taking part in it. They're showing their part. They're saying, what are the women saying? What are the spouses saying? And already some things have started to change. Just the quick fixes that don't take a lot of money, or that just take a policy change, reallocating money so that more family members can come. There are family homes that people can stay in, those kinds of things. That's already happening. And we're only in the very first stages of the project. So in this setting, there's not the conflict. Everybody wants to see the change. We have a lot of optimism about where this is going to go. The methods are exactly the same as you saw in other countries. So now there's another project, also in Nunavik, that takes on a slightly bigger role. This is about the way that the institutions work. One point that, everybody in Quebec knows it, but many of the people on this call are from outside Quebec and probably won't know it. Okay, I'm already at 45 minutes and probably won't know it, but almost all service providers, and certainly the more qualified ones, come from outside of the region. They come from the south. They are not Inuit. And what this has led to over the years is a very strong institutional racism that people don't like and they don't want. And both sides, service providers and Inuit, want to see this thing gone. They want to deal with it. And so we're making that a focus of this, and we'll work in each of the 14 communities in Nunavik. And we'll arrange that work as we go through co-designing very local strategies. What needs to change here right now? the way that we'll do it is exactly the same as you've seen, define the problem, measure it, design the fixes, put the fixes into place, and then measure impact. This proof of impact is what's going to be very different about this project. I've mentioned that there's a lot of evidence on cultural competence because it's been studied. There's very little evidence on cultural safety because it has not been studied. And so part of our task in this project is to get the evidence, get the hard evidence. So there's another part to it, updating the written word and the cultural safety of the written word. If you do a literature review, whose views are you getting? And how can a systematic review be culturally safe? So this is work that was developed by Anna Dion for her PhD, worked out very well. She did a fantastic job. What she wanted to know is how can you revisit a standard literature review and take into account the voices of those who have been excluded from the literature review? It sounds not doable. In fact, she worked out a very good way to do it. You basically update the literature with the stakeholder experience. And she called this the weight of evidence. What it basically involves is asking what the research tells us, what do the people tell us, put the perspectives together. This can be either very elaborate. We use Bayesian updating. You can also do it just with one table and another table, a pattern matching table. Explain the difference and why there's this difference, and ask what the action implication is. So the take home from this particular approach of culturally safe research is that sometimes you're in a situation that, and this is again shared by the lead researcher on this project, by Anna Dion, that sometimes you're in a situation where you can't put the people in the same room. The Mexican situation was one like that. But what weight of evidence does is that you can get a more level playing field, or part of the playing field more level, by not going with just what is known by those who are rejecting the views of the less dominant group. So the next part of this is about training, because clearly a big part of the problem in cultural safety in our experience is that nobody knows much about it. It's not so much a problem in training researchers. Anyone who goes through family medicine has to take one of my courses. So you take one course if you're master's, another course if you're doing PhD, and they do well. The people do very well. They land up doing good research, and it's relatively easy. What's much harder is training for clinical work, because people get right the way through their residency without hearing the word. Less so now. In the last few years, things have been changing at McGill. But across the rest of the world, people can finish their residency in family medicine and just about anything else and not even hear the term cultural safety. So that's where this work of Juan Pablo Pimentel comes in. This is really groundbreaking work, where what he did was recognize that you can't just pop in a couple of extra months in an undergraduate training career and expect medical students to go through a couple of months. There's no time. You don't have the couple of months. The second thing is that a lot of medical students think that they're okay. You know, they don't have bad attitudes. They don't, in a way, have reason to be told that you have to learn humility, that you have to be reflective. They don't really see the need for that coming into it. So there's not a particular interest in it. But what he did was he adapted serious game learning into learning about cultural safety, and got medical students and residents to design serious games about cultural safety. The long and short of it is that they became quite experts in cultural safety, and the games were interesting as well. And he fitted that into 8 hours. So that particular breakthrough means that you can contextualize the curriculum, a general curriculum, using local authorities, and you can have medical students take that on board and change themselves through doing the learning together. Now, he used a very similar set of categories to the ones that I presented at the beginning, where he basically showed a scale, not a continuum, but steps that you have to take before you reach cultural safety, between risk and awareness and humility and competence, going through to cultural safety. And he got a group of traditional knowledge holders, intercultural researchers together to provide content on each of these things. And it was that content that the students used to develop their games. So there are innovative, groundbreaking approaches to training in cultural safety that put us in a very different position now. Finally, a few words on intercultural dialogue, which is something I've referred to all the way along here. In our work in Mexico, it turned out that there were 3 broad steps. The first was to start the partnership with fuzzy cognitive mapping or other way. The second was to generate the evidence that would take that forward. And the third was to co-design and evaluate together what the programs that emerge. These are steps that open the dialogue. The actual dialogue is what happens when people meet up and can discuss. But what we found is that you have to construct a ladder. And what I've been describing to you today are those steps into a ladder that we define the problem, we make sure we've got it right, we quantify it, we co-design it, we measure the impact of it. The measuring the impact is a refrain of mine that I've been going on about. There is nothing that convinces as much as success. And if you have a measurement, quantitative and qualitative, if you have a measurement of what works, people get on board. If you can add to that the economics of that, so much the better. So Germán Zuluaga, who I didn't see on this call, but several of his students are on this call, articulated a very nice way of explaining this problem of cultural safety. And for those getting tense, this is right near the end, so not long to go. Where in our Western health system, we're very used to dividing it up into task levels and skill levels. The traditional health system we see as this opaque thing a long way away without differentiating at all. And this is the approach that's compatible with cultural risk, just seeing this other as something that we have to deal with, but we wish we didn't. When we get to see traditional health systems as having their structure and having what is special to them and their content, that's when we're getting into the realm of cultural safety. And when we start interacting these two systems, when people start talking about self-care across the boundaries of traditional and Western, when people start talking about midwifery across the boundaries of Western and traditional. And at that level, there's no problem at all to say, well, look, if the dialogue, we're not saying that these are the same. We're not accepting the points of the other. We're just saying we can talk about it. And it's probable that an obstetrician, a senior obstetrician, will not really have much to say to a senior shaman who deals with pregnancy issues. It might be they don't. And that doesn't matter. What matters is that we're prepared to recognize and we're prepared to talk about it. So in wrapping up, I mentioned the work in Nigeria led by Anne Cockcroft that showed men as part of the solution if we open this up and we go against the medicalized view that women are patients and men are out of the picture. Going against that brings men part of the solution, and it works. It works big time. The idea of using a culturally safe method to address what everybody sees as a major problem. Kunika, also led by Anne Cockcroft, led by Lubna Belay, the recognition that it doesn't all happen at once. The fact that you've started working is not going to mean you've solved all of this. It just means that you've started it working. In Mexico, the proof that that safe birth and cultural safety is here. We can prove it. And there's the economic argument that it works. And the Nunavik, the value of measuring the impact of all of that and the leveling of the playing field that we get even with a systematic review. So I hope I've managed to convey the starting point, some parts of the steps in between, and hopefully some enthusiasm for reaching the other end of this. Alice, to you.
Thank you so much, Neil. Thank you so much for your presentation. We have a couple minutes left for questions. So if anyone has a question for Neil, please type it in the chat or raise your hand virtually. Yes, I see Marion.
Hi, thank you, Neil, for this fascinating overview of your work in culturally safe birth. And as someone who for almost 25 years has done deliveries at the Jewish General Hospital right next door, I'm struck by the similarities with the system in Quebec. So back in the 1990s, midwives were not authorized to do deliveries in Quebec, and they used to work in the north only with the Inuit, and they were trying to get a foothold in southern Quebec, but they received sort of a cold reception from the medical establishment. And it was actually a family physician in Côte des Neiges, Dr. Vania Jimenez, who connected with the midwives and said, we will assure your safe transfer of any patients that need it to get to the hospital. And that was how midwifery came into being in the south of Quebec. So I'm just sort of fascinated by the similar kinds of stories going on around the world, and the fact that in Mexico, the midwives or the traditional birthing attendants wanted safe passage of their patients or their women to hospital. It was just fascinating to me. So thank you for that.
Thank you.
Yeah, while others are thinking about their question, I also want to echo, thank you for this great presentation, very enriching and inspiring. And I think congratulations for all the students, also the work of the students have presented. I think that's amazing and very pertinent to many aspects of clinical care, even locally. Thanks.
Neil, my colleague Pearl Feldman is asking if we could get obstetricians to listen to your talk. And I'm wondering if you would be interested in presenting to obstetricians, if we could arrange an invitation.
Sure, be honored to. Be honored to. I think the more we can get people discussing these issues and what they mean in their own practices, the sooner things are going to change. I would like one outcome of this talk to be the pressure that we really need to be doing things differently if what we want to talk about is safe birth.
Justin?
Yeah, thank you so much for this talk. I enjoyed it so much. And I couldn't help but thinking about safe practices at the end of life as well. But I'm thinking about the work of folks in the lab where I came in Boston at Ariadne Labs. We're doing a lot of work around trying to develop standardized tools that supported safe childbirth. And so they developed, for instance, a safe childbirth checklist that they implemented in India. It was the largest clinical trial in history, funded by the Gates Foundation. And ultimately, it was they had a negative outcome, or a null outcome, I should say. But they learned a lot in the process. And I'm just curious about this tension, what seems to be a tension between culturally safe childbirth practices, which in a multicultural society, present challenges in an institution like a hospital, if that's where it's being delivered. But also in thinking about how we develop systems that support safe childbirth, in ways that sort of rely on routinization to some degree. So I'm just curious if you can comment on that tension.
Yeah, thank you. I love this question because it gets to the heart of what we're doing wrong. If ever for you, or I've got a training program for you, please just think what you would say if somebody came to you in your practice and told you that. If somebody from Mexico came to you and said, I've got a template for you to do something differently, and you can do it my way, what would your reaction be? It's kind of like a no-brainer. So if somebody comes to them, probably even in a different language, and says, I've got a template of what the fact that your grandmother did this, your mother did this, and you've been doing it for 50 years, but now I've got a template for you. You can just see why that's going to be a sort of no. And it can stand a fair chance of being dangerous because it can not integrate well with the knowledge pattern. Whereas if you just say, what help do you need? And what can we do to help you? And open the dialogue with that. And then point by point, start saying, well, how do you cut the cord around here? And what do you do for this? And what do you do for that? That way, if you're looking for something prescriptive, a dialogic approach works. And I think all of our projects are testimony to that. A prescriptive, top-down, alienating, culturally insensitive, and probably contextually inappropriate. And by contextually inappropriate, I mean it's completely inappropriate for a Mexican midwife to come to, or end of care specialist to come to you and say, look, I've got this formula for you to follow. It's completely inappropriate, as it is for you to do something in the other direction. But what's not inappropriate, if you notice that there's space to help, what is not inappropriate is dialogue. And so the whole trick is to open the space for that dialogue. And the way that we do that is always with evidence. It's not with my beliefs are more important than your beliefs. It's with, let's look at the situation. How do you see it? How do I see it? What's the difference? Why is the difference? And then measure. Who's in what situation, and then talk about it. You would probably land up achieving what you wanted to achieve in the sense of those things that you felt were translatable into a template are also translatable into a dialogue and a discussion, not an imposition. So it's not that you've got nothing to contribute. Absolutely not that. We're all good, strong health workers, and we've got stuff to contribute, but we have to work in a culturally safe way. And so that evidence starting, open space for dialogue, have the dialogue, do it and measure it. And that's where the sustainability comes from. That's where it stops being just you in this little place with that one person that you were working with. When you start measuring the impact, and then they've got something to discuss, you've got something to discuss, and the international community has got something to discuss, because there is so little empirical work on this.
Thank you.
But thank you for the question. I love that question.
Anybody else with questions? I think just a lot of thank yous in the chat, Neil. Yeah. Thank you so much for joining, everybody. And thank you again, Neil. Our next seminar will be April 1st, presented by Dr. Samir Rahimi, who is also a prof in the Department of Family Medicine. And the seminar will be titled Moving AI Forward in Primary Healthcare, Technical, Ethical, and Practical Considerations. So the registration link is in the chat, and hope to see you there. Have a lovely weekend, everybody. Thank you.
Thank you, everyone.